Now we're going to get into the way that it is done using testosterone, bioidentical hormone. The first thing you need to know, again, is the review of the hypothalamus pituitary testicular or gonadal axis. The hypothalamus releases gonadotropin releasing hormone, which communicates with the pituitary, which then releases FSH and LH to the testicles, which then produces testosterone. Testosterone feeds back on this whole system and shuts down the production of testosterone itself. And testosterone also goes to all the other body tissues, the fat cells, the muscle cells, the brain, etc. Now, what we want to think about here is how we can interrupt this whole process. Many people do not understand that bioidentical testosterone therapy is not the same as anabolic steroid use. Anabolic steroids are synthetics that look similar enough to testosterone to stimulate some of the body structures that testosterone does, but not all of them, but also does indeed shut down the hypothalamus pituitary testicular or gonadal axis. Here you see where the synthetics can block your own natural production of testosterone, yet at the same time not have the full testosterone health benefits because they are not bioidentical and do not interact with all the tissues that testosterone does. After all these things are not bioidentical hormones. This is not what we're talking about with TRT therapy. Here you can see between these two lines in the center, this would be normal testosterone levels where we want to stay and keep the body. We do not want levels going too high, spiked too high, nor too low. And when it goes too low, we can have some mood issues and decreased whole body effects in terms of performance and recovery and erection and things like that. So really we want to keep the blood levels in this range here. And so we want to dose enough and frequently enough to make sure that the blood levels stay adequate for testosterone replacement therapy. Now, here's some of the things you want to concern yourself with, which typically your doctors will recommend: gels, patches, buccal implants, and things like that. It's the most popular gel that doctors prescribe, the patch known as androderm. And there's also new buccal forms, basically in the mouth, testosterone, as well as implantables in the body as well. Let's go through some of the goods, pros, and cons of these things. First of all, the gels have a random release pattern because of the way they are absorbed through the skin. This can mimic, probably more accurately, some of what happens in the body. Testosterone is pushed out in pulses versus all at once in the body. However, that might be a good thing, but gels don't adequately seem to achieve the high end of normal range that we would be optimally trying to produce in testosterone replacement therapy. So while the gels might give you this random release pattern and not spike too high, they often have a very difficult time getting the blood values to where we want them to be. The patches, because they are on the skin, the buccal implants and the body implants can definitely be a solution, but we have to consider things like kissing your partner and basically trading testosterone that way. We also need to realize that when we test and then we get a testosterone therapy, we want to retest and adjust. These implantable devices are very difficult to adjust because they're typically put in and left in for 3 to 6 months. And so the gel doses, 1 to 1.6% gels, 2 to 4 pumps in the morning. The patches, you're basically going to put a patch on every day, rotating the positions, and then you're going to repeat. You're going to make sure you do not repeat the positions for up to 7 days. The implants, this is 2 to 6 pellets, which are basically 75 milligrams of testosterone each, basically put in and last for 3 to 6 months. We also want to avoid some of the sweating. Oftentimes the patch, the gels, they are not adequate for those reasons. The bioidentical injectables are going to be the way that most people want to go. Now, I do realize that injections scare people a little bit, and I'll tell you a little bit about that here in just a minute. The cypionate, the enanthate, and the propionate, those names just basically tell you what kind of ester is attached to the testosterone. Cypionate has a long ester, enanthate a long ester as well, and propionate a shorter ester attached to it. And this will impact the half-lives in the body of each of these compounds. Cypionate half-life is 6 days, enanthate 5 days, and propionate 2 days. So basically looking at this, you kind of want something that you can basically create a high enough amount and adjust it on a regular basis. And for these reasons, I prefer propionate to all these others, although that's more difficult to find. Most of you are going to be dealing with cypionate or enanthate. The dose for cypionate and enanthate is exactly the same. 50 to 100 milligrams every third day is the dose that I recommend. Keep in mind here that many doctors will dose it 10 to 14 days later, and you should adjust that dose with your doctor and let them understand why you're telling them that you don't want to do that dose. After about 7 to 10 days, blood values begin to fall, and you can have testosterone rebound. You want to make sure that you keep adequate levels in the blood at all times. This is why an every third day, twice per week dose is better than a longer dose. Propionate is dosed 25 to 50 milligrams every other day. There's also some other forms of bioidentical injectables that you probably want to stay away from because they either don't have enough research or they're just harder to come by. It basically is testosterone undequinate and some other testosterone forms that basically do very well in the system. It's just harder to come by. Testosterone undequinate, but there's some more preparations now that last very long in the system. And then testosterone suspension, which you're never going to want to use because it can create huge spikes in the body, and you get a lot of aromatization and negative feedback from suspension. Many of the doctors will prescribe, and others, and these are long weeks before injection. So this undequinate or Aved will stay in the system for a long time. This may indeed eventually be a preferred method, but right now the research does not suggest that, or there's not enough research to let me basically change my recommendations of using cypionate, enanthate, or propionate. There's going to be a couple drugs that you may want to be aware of to use in addition to the testosterone bioidentical. Here you can see where testosterone bioidentical is having its effect. We are putting testosterone directly into the system. We can mitigate some of that by giving HCG along with the bioidentical testosterone. Clomiphene is Clomid and Nolvadex is tamoxifen. These can block back the feedback of estrogen on the hypothalamus.